All right, we're going to cover the child with cardiovascular dysfunction. And right now we're going to look at some of the pathological changes. Before we do that, let's talk about what the congenital heart disease is. Incidence is 5 to 8 per 1,000 live births. 2 or 3 of these infants are symptomatic in the first year, but congenital heart disease is a major cause of death in the first year of life, and that's second to prematurity. Most common anomaly is ventricular septal defect, and we'll show that when we are looking at some of the pictures. You're really going to want to understand the heart anatomy to really understand these congenital heart diseases. In 28% of the kids with congenital heart disease, another recognized anomaly is also present. So there are two types of cardiac defects. One is congenital and one is acquired. So congenital would be some anatomical defect, and that results in abnormal function. The acquired has to do with the disease process. So, for example, an infection where you end up getting a structural defect, or an infection, you have rheumatic fever that leads to a heart regurgitation or valve regurgitation, or you have an infection leading to inflammatory structural disorders, autoimmune response, environmental factors, or familial tendencies. So the causes, chromosomal or genetic cause, maternal or an environmental cause, and 1% to 2%. So maternal drug use, so those with fetal alcohol syndrome, 50% of those children have congenital heart defects. Rubella infection in the first 7 weeks of pregnancy, or some other infections, toxoplasmosis, viral illnesses can lead to cardiac defects. Those can also lead to cleft palate defects. Infants of diabetic mothers have a 10% risk of congenital heart defect or congenital heart disease. Ventricular septal defect, cardiomyopathy, and transposition of the great arteries are the most common, and you'll understand those when we look at those pictures. Okay. So you have the normal fetal circulation changes. So when the newborn takes the first breath, the fetal vascular system changes. So you have your umbilical vein and umbilical arteries. So those, before birth, the umbilical vein delivers oxygen and nutrients to the fetus, right? And then the baby is no longer needing the umbilical area, so that area will close. The foramen ovale closes as pressure in the left atrium exceeds pressure in the right atrium. And the ductus arteriosus starts to close in the presence of increased oxygen. So here's your picture. So you have, see how most of this is oxygenated, right? So this is oxygenated for the prenatal circulation, because all the oxygenated blood is coming from the umbilicus. And then the postnatal circulation in B, now it's coming, the deoxygenated blood is coming through the right side and then going into the lungs, the pulmonary arteries, to get oxygenated. Because now in figure A, it's bypassing the lungs, because the child is obviously not breathing. The child is in the womb. So you can see how there's the patent ductus arteriosus between the aorta and the pulmonary artery. So that is patent, right? So that doesn't need to, that is patent because all the blood is oxygenated. There doesn't need to be any differentiation. And then you also have the foramen ovale, which is the atrium between the two atriums. And so that's open, and that doesn't need to be closed, again, because we're dealing with the oxygenated blood. It needs to close, of course, in figure B, the normal function of the heart. You're looking at where the blood flow comes in, the deoxygenated versus the oxygenated. So you really want to get a handle, and you can come and look at the anatomy model to get a handle on the perfusion and what that means. So history indicators of cardiac dysfunction. Symptoms may appear 4 to 12 weeks after birth. So this child, failure to thrive, poor weight gain, activity intolerance. There's some developmental delays because all the energy is going to blood flow, not going to neurological and development. Positive prenatal history, that was like the fetal alcohol syndrome. Positive family history of cardiac disease. Physical indicators of cardiac dysfunction. So now remember, if you can't breathe, you can't eat. So breathing and cardiac has to go together. So if the heart is not functioning correctly, then nothing else is going to function. You might have crackles in the lungs, and that's from the blood flow, right? So this child might get congestive heart failure. Cyanosis is evident because deoxygenated blood is going to the area, not oxygenated blood. You will hear a murmur, especially in those open, if there's a patent ductus arteriosus or any other holes where blood is not flowing where it should be. Clubbing of the fingers, also with respiratory disease. So this is, you'll have this in cardiac dysfunction or respiratory dysfunction. The older classification of congenital heart disease, they were called acyanotic, that could become cyanotic, or cyanotic, where they may develop into congestive heart failure. But now they are classified as hemodynamic characteristics: increased pulmonary blood flow, decreased pulmonary blood flow, obstruction of blood flow out of the heart, and mixed blood flow. And the next videos are distinguished by those blood flows. So we'll do that next. Thanks.